Hi everyone, my name is Cindy. I'm a clinical pharmacist from HPS Pharmacies, Sunnybank. Today's topic is going to be about iron infusions. Iron deficiency is common and is often caused by either inadequate dietary intake of iron, malabsorption, for example with celiac disease, or increased iron requirements, such as during pregnancy. Iron deficiency is diagnosed through the measurement of serum ferritin, which is a more accurate measure of total body iron stores compared to serum iron concentrations. Iron deficiency is managed through iron supplementation, which can be administered either via the oral route or the intravenous route. The advantages and disadvantages of each route are summarized in the table showing below. For oral iron, the main advantages are that it is inexpensive, it is equally effective compared to intravenous iron in increasing hemoglobin concentration, and it is generally safe. The disadvantages are that there are gastrointestinal side effects, which can reduce adherence. The main advantages of intravenous iron are that it allows for rapid replacement of iron and rapid increase in hemoglobin levels compared to oral iron. Compliance is assured. It overcomes the need for gastrointestinal iron absorption, and there are fewer gastrointestinal side effects compared to oral iron. With some preparations, the total dose, which is usually around 1,000 to 1,500 milligrams, can be provided in a single infusion. It is effective in the presence of inflammation, and there are decreased number of hospital or clinic visits. The main disadvantages include potential for iron infusion reactions. It is more expensive compared to oral iron. It is contraindicated in those with infections during first trimester of pregnancy and in patients with a history of iron allergy. Iron is usually administered through the intravenous route because iron is poorly absorbed from the intramuscular route. In addition, administering iron through the intramuscular route is painful and frequently causes permanent skin discoloration at the injection site. The indications for intravenous iron include when oral iron is contraindicated, ineffective, not tolerated, or unlikely to be effective, if correcting iron deficiency anemia is considered urgent and there is a clinical need for rapid iron supply, iron malabsorption from gastrectomy, duodenal bypass, H. pylori infection, celiac disease, atrophic gastritis, inflammatory bowel disease, genetic iron refractory iron deficiency anemia, in chronic bleeding states that are not manageable with oral iron and where iron loss exceeds absorptive capacity, in severe iron deficiency anemia in the second and third trimester of pregnancy, if the benefits of treatment outweigh the potential risks to the fetus, in patients taking erythropoiesis stimulating agents, for example, in anemia of chronic kidney disease, and in patients with heart failure with iron deficiency. Contraindications for parenteral iron include patients with a history of or known anaphylaxis or hypersensitivity to intravenous iron or its excipients, iron overload states such as hemochromatosis, anemia that is not due to iron deficiency, severe inflammation or infection of the kidney or liver during the first trimester of pregnancy, and it is to be used with caution in patients with active systemic infections. Intravenous iron preparations that are available in Australia include ferric carboxymaltose, known as Ferinject, ferric derosomaltose, known as Monifer, iron polymaltose, known as Ferrosig, and iron sucrose, known as Venofer. So the table below shows a comparison of each of the different iron infusion preparations. So the first one is ferric carboxymaltose. So main things to note are that it allows for a rapid infusion. Up to 1,000 milligrams can be given in a single administration in those that are over 35 kilograms. However, this 1,000 milligrams dose cannot be exceeded within 7 days. So repeat doses may be needed to meet the total iron requirement. However, the main advantage is that it can be given in the community or in an aged care facility. The next one is ferric derosomaltose, which is known as Monifer. With this preparation, you also need to wait at least 7 days between infusions. The main advantages also are that it can be administered in the community, and there is generally a lower risk of hypophosphatemia compared to ferric carboxymaltose. However, the disadvantage is that it is more expensive than iron polymaltose and iron sucrose. The next one is iron polymaltose, known as ferrosig. The main things to note are that up to 2,500 milligrams can be given in a single administration for those that are greater than 35 kilograms. However, a long infusion time is required, and it can only be given as an inpatient. It is approved for intramuscular route, but as mentioned before, there's usually poor absorption, it's quite painful, and staining of the skin can occur. And the last one is iron sucrose, which is Venofer. This one is used in hemodialysis patients. 100 milligrams IV is used during dialysis up to 3 times a week. It is a strongly alkaline solution. Main advantages include that there is a lower risk of adverse effects compared to iron polymaltose, and the disadvantages are that it is more expensive compared to iron polymaltose. With regards to administration and dosing of intravenous iron, the doses of intravenous iron to be administered are generally calculated using the Ganzoni method, whereby the patient's weight and hemoglobin concentrations are needed. So the formula is elemental iron in milligrams equals the body weight in kilograms multiplied by the target hemoglobin minus the actual hemoglobin in grams per liter multiplied by 0.24 plus iron depot. The iron depot is 15 milligrams per kilogram body weight for body weights that are less than 35 kilograms, or 500 milligrams for body weights that are greater than or equal to 35 kilograms. In general, blood pressure, heart rate, oxygen saturation, temperature, and cannula site appearance should be monitored prior to the infusion and at set intervals, usually every 5 minutes, depending on the specific local protocols and population groups. Intravenous iron supplementation is generally well tolerated. However, if any suspected adverse reactions to parenteral iron occur, the infusion should be stopped immediately and a medical officer notified. Side effects of iron infusions include staining of the skin, which can result in permanent skin discoloration. This occurs if there is extravasation of intravenous iron during administration, so staff administering the infusion should be educated to observe any pain or swelling at the administration site, and the infusion should be stopped immediately. Anaphylaxis symptoms include wheezing, stridor, sweating, tachycardia, dyspnea, dizziness, hypertension, and cardiac arrest. If this occurs, it frequently occurs at the start of the infusion, within the first few minutes. It is important, therefore, to ensure adrenaline is available if required, and that staff are trained in the management of anaphylaxis. Flushing, dizziness, or lightheadedness within the first few minutes of starting the iron infusion, which is generally self-limiting and lasts a few minutes. Influenza-like symptoms a few days after the intravenous iron infusion, which are generally self-limiting but may last up to 8 days. These include nausea, headache, dizziness, fever, diarrhea, fatigue, rash, and myalgia. Hyperphosphatemia, which is usually transient and has been reported around 5 to 20 days after the intravenous iron infusion. It is more likely to occur in patients with pre-existing vitamin D deficiency, low calcium levels, low phosphate levels, or raised parathyroid hormone levels. Symptoms include vertigo, nausea, general weakness, tingling in the hands, and depression-like symptoms. Assessing response to iron infusions. The patient's response to intravenous iron infusions should be checked 4 weeks after therapy by measuring hemoglobin and ferritin levels. After 6 months, full blood count and iron studies, including serum iron, ferritin concentrations, and total iron binding capacity, should be measured. Patients who have continuing gastrointestinal bleeding should have their ferritin levels checked more often and may require frequent infusions. In summary, there are 4 iron preparations for IV use. They are not interchangeable. Dosing and administration advice should be sought from local protocols and product information leaflets. It is generally well tolerated, but serious adverse effects can still occur. Thank you for attending this presentation. Here are some self-assessment questions. The first question is, what advantage does intravenous iron offer over oral iron? A, it is less expensive. B, there are generally fewer gastrointestinal side effects. C, it allows for rapid replacement of iron and rapid increase in hemoglobin levels compared to oral iron. Or D, both B and C. Question 2, which of the following is true? A, intravenous iron can be used in the first trimester of pregnancy. B, the maximum dose of ferric carboxymaltose in a single administration is 2,000 milligrams. C, the Ganzoni formula requires the patient's body weight and hemoglobin levels. D, Iron deficiency infusions can be used in those aged at least 14 years old. And question 3, which of the following adverse effects could occur within the first few minutes of an iron infusion? A, dyspnea, B, dizziness, C, hypophosphatemia, D, pain at the injection site, or E, A, B, and D? The answer to these questions is 1, D, 2, C, and 3, E. Thank you very much.